Could all the presenters please come to the front row?
Hi, Gabby.
Thank you.
TB diagnosis and treatment is... Do you see? No. Okay. No. Okay. I know. So we'll get started in just a couple minutes. We're just waiting for a few more people to arrive. ¿Puede cargar la primera ponencia para... Yeah. Okay. Okay. Gracias. So good morning, everybody. Thank you for coming. It's the last day of the conference. It's been a busy week for all of us. My name is Jacob Cresswell. I work at the Stop TB Partnership, and I'm here with my co-chair, Carol Nawaina. Sorry for the mispronunciation. And this morning we're talking. We have quite a few oral abstracts that are talking about all different aspects of cost, and cost to the patient, cost to the health system. It's something that in the new NTB strategy, there's really, for the first time, a focus on the impact of costs to people who need screening for TB, people who are on treatment. WHO is launching a series, and you'll hear about a number of them, I think, of patient cost surveys. And so it's a new field, and we're quite excited to hear a lot about quite a few of the new studies and thinking around costs for people who have TB. So I'll pass it to Carol to introduce the speakers. I think they're short presentations. What we would like to do is we have the first four speakers up on the stage, and they will present. And then if there's questions for the first four speakers, we'll take a few questions, and then we'll invite the next four speakers up to the stage and do the same thing.
Thank you, Jacob. My name is Carol Nawaina. I'm from Sitam Plus from Zambia. So like Jacob said, I'm co-chairing with him. So our first speaker is Deborah Pedrazzoli, and she is a research fellow at the London School of Hygiene and Tropical Medicine. Her primary research interest is in the socioeconomic epidemiology of TB and in evaluating interventions to address TB and social inequalities. And I think she'll be sharing with us findings from a nationwide TB patient cost survey in Ghana. Deborah.
Thank you, Carol. Good morning, everyone. So we are starting this session from West Africa and in Ghana, as Carol said. So as Jacob mentioned, the anti-TB strategy includes a new target of having zero TB affected family facing catastrophic costs due to TB. In order to monitor progress towards this milestone, the WHO has recently developed a tool that countries are expected to adapt and to use to conduct surveys to monitor progress towards this target and to assess the occurrence of catastrophic costs in their settings. So we adapted the tool in Ghana, and we conducted a cross-sectional nationally representative survey amongst patients on treatment at facilities within the NTP network. Just three quick points about the survey setting that I would like to make. The first one is that despite positive economic growth for the past 2 decades, Ghana is still characterized by a quarter of its population living below the poverty line and by striking inequalities. The second point I would like to highlight is the TB situation in the country. So we had the impression that Ghana was doing quite well at controlling its TB epidemic, but a prevalence survey that was conducted in 2013 found out that the burden of disease is in fact 3 times higher than we previously thought. And the survey also highlighted that there are high barriers to accessing and adhering to TB care. In Ghana, TB care is meant to be free for all, with the exception of chest radiography, which is about $8 per chest X-ray. And lastly, Ghana is a lower middle income country with a reasonably well-developed social protection flow. And here again, 3 things I'd like to point out that are relevant for TB patients. So the first one is the National Health Insurance Scheme that was launched a few years ago and covers like about a third of the Ghanaian population, but only people are enrolled in the formal sector of the economy. The second thing is the Enablers package that was launched again in 2003, and this is specific for TB patients, but it's currently being phased out. And lastly, the Livelihood Empowerment Against Poverty Social Protection Scheme, which was launched as part of the National Social Protection Strategy in 2007, and is aimed at the rural poor. Right, so some preliminary findings. Sorry. So we had a total of 691 eligible patients in our study. Just a quick thing. The data collection took place in November and December last year. And we enrolled 691 patients in the study. Sensitive TB patients incurred about $850 per their TB episode, while drug-resistant TB patients incurred double this amount, actually more than double this amount. Indirect costs accounted for the larger proportion of this cost. You can see the light blue share of these donuts, and followed by expenses on food and on medical costs. So at a threshold of 20% of annual household income, which is the current threshold recommended by the WHO, more than 2/3 of patients in our sample experienced catastrophic health expenditure due to their TB. And an additional 14% of patients were pushed below the poverty line due to TB. We also collected data on receipt of social protection during our study, and we can see this catastrophic health expenditure happening despite the fact that patients, for example, 80% of our patients were enrolled in national health insurance schemes, so they were supposed to have free access to TB care. And a small proportion of them, just over a quarter, are still receiving the Enablers package in the forms of goods or vouchers of in-kind, and especially receiving food support like flour and supplements from the clinics. So, in conclusion, I think our findings show that despite the fact that TB care is supposed to be free in Ghana, patients are still experiencing catastrophic health expenditure due to their disease. And the current social protection policies, like for example the National Health Insurance Scheme, are clearly not effective in preventing these catastrophic expenditures. So really what we should try and do, like looking at the findings from this survey, is to then try and develop policies and identify entry points to try and mitigate these costs, so trying to avert catastrophe and alleviating the impoverishing effect of the disease. Thank you, and I would like to acknowledge the collaborators of the studies and whoever contributed to this piece of work. Thanks.
Thank you very much, Deborah. We'll take, as I said, questions at the end, but I think it's nice. These surveys that are just beginning to come out are allowing us to really highlight the major impact that as Deborah said, free treatment is having on patients, and I think that is the first step towards moving towards the zero catastrophic cost that we have envisioned as a community for people who have TB. So thank you very much.
Thank you, Jacob. Our next speaker is Tom Wingfield, and Tom is a physician and academic clinical lecturer in infection at the University of Liverpool and Karolinska Institute in Sweden. His research interest is in addressing social determinants of infectious diseases with a current focus on TB. Go ahead.
Thank you very much. Muy buenos días con todos. So I'm going to talk to you about a feedback from Peruvian TB-affected households after a socioeconomic intervention. And the work that I'm presenting is on behalf of this wonderful Innovation for Health and Development multidisciplinary team, headed by Marco Tovar and Carlton Evans out in Peru. So we've known for about 150 years or more, and Virchow recognized it 150 years ago, that TB is a social disease. And 100 years ago in the UK, with the Papworth Village Settlement, we tried to deal with that by providing TB-affected households with employment, with good nutrition, and regular health checks, and that actually led to decreased rates of secondary active TB disease in children of those households. So 100 years on, our group was awarded a grant to conduct this community randomized evaluation of socioeconomic intervention to prevent TB. And this was preceded by a household randomized study, which I'm going to talk to you about today. So this study site is in Lima. It's actually specifically in Callao, 32 shantytown communities, covers about 1 million people in population, does have a level of poverty there, and some pockets of gun crime and drug addiction. What did we want to do with the kind of greater aims of the study? We wanted to find, prevent, cure, and control TB. And how to do those things? Well, you need to screen contacts for TB infection and disease. Those contacts who have infection need to start and complete preventive therapy. And the patients who have TB ideally should adhere to their treatment and complete the treatment for cure. But apart from all of that, we also want to educate, inform, and reduce stigma for those households. So we randomized 282 households, 135 of which received this socioeconomic support intervention. So the social support consisted of household visits, which were educational, health post visits, which were the same, and community meetings, which had two parts: a workshop about TB, its transmission, how to gain cure, and also mutual support groups to try and reduce stigma and empower TB-affected households. The economic support on the right side was provided by conditional cash transfers throughout treatment for all of the things you see in the green boxes, including engaging with the social support side of the intervention. And they totaled $230 US, which was 10% of annual income of TB-affected households in our area. So the initial findings were that we increased preventive therapy initiation in contacts, we increased treatment success in patients, and we decreased catastrophic costs in households. But what was the feedback from the participants on the acceptability of the social and economic elements of the intervention? Probably one of the most important parts of the results. And did this vary by poverty level? To answer that question, we performed a mixed methods questionnaire at final follow-up, so usually at about 6 months of treatment. And we asked participants to rate the intervention, so excellent, good, neither good nor bad, bad, awful, and rank them, so highest rank of which of those elements, which I'll show you there, they preferred. So the social elements we divided into information and education and mutual support, and the economic elements we divided into incentivization, enablement, and poverty reduction. Now, obviously, incentivization, that could fit both groups, but we put that, in this case, in economic element. So what did people say overall? So this is the proportion of respondents who said in the darker parts of those columns, so the bottom two dark parts of those columns, it was good or excellent. So you see from left to right, we've got the information and education, mutual support, which together are the social elements, and then we've got incentivizing, enabling, and poverty reduction. And I think what you'll note overall is that over 80% said that they were good or excellent, except for poverty reduction, which still had really overall good acceptability, but a bit lower than the others, at about 70% rated as good or excellent. This is slightly busy, but when we split things by poverty level, this is now ranking. So this is not good or excellent. This is which of all those elements did you value most within the intervention. The top p-value there shows the comparison of social elements grouped together versus economic elements of the intervention. So the left two columns versus the right three columns. And the other p-values are really comparing the lighter grey bars, which are the poorer households, versus the darker grey bars, which are the less poor households. So overall, we can see that the economic elements were actually ranked lower in importance by the households than the social elements. And specifically, if you just look at the right-hand two columns, the reducing poverty section, there was a significant difference between the poorer households who ranked the reducing poverty part of our intervention as lower than the less poor households. So overall, the intervention was acceptable to TB-affected households. The social elements had good feedback regardless of poverty level. And the economic elements were ranked lower than the social, especially in the poorer households and especially with regards to poverty reduction. So I think we need to consider whether or not we should be targeting perhaps enhanced support for the most impoverished or other groups, for example, those with multi-drug resistance. But I also think in this wider conversation about catastrophic costs, we need to realise that this type of intervention, it is not really a poverty reduction intervention. It is mitigating costs, yes, but the situation that people live in, it remains the same. So it's not really a poverty reduction intervention, but it hopefully might stop people going further into poverty. Thank you very much.
Thanks very much, Tom. I think the work that Tom and especially the team at Prisma in Peru and others in Latin America is really at the forefront of looking at social determinants and these issues and raising a lot of early questions that hopefully a number of others will take up. So it's nice to see that more in-depth thinking about how this is going to work in the future. You want to introduce?
Okay, thank you. I think our next presenters were supposed to have been from Brazil, but actually they sent me an email to say I should pass their apologies, to say the NTP and team from Brazil were not able to attend, and they passed their apologies. And I think the next presenter is Alexandra Katsaga, and he is a health policy, financing, and health information system expert with extensive practical experience globally. He is also involved in the development of the TB DRG system in Kazakhstan and Ukraine. He has also developed M&E systems for evaluating the effectiveness of provider payment for methods and their influence on healthcare providers. And he'll be looking at analyzing clinical and cost data for effective use of domestic resources for TB, and will be giving us the case of Ukraine.
Thank you very much. Dear colleagues, it's very difficult to provide all details and say story within 6 slides and 6 minutes, but I will try. First slide, please.
Are the slides?
No slides? Okay. So some technical difficulties. So I will start from a short description of how it was started. Recently, Ukraine started very radical reform and health financing system because old system was very inefficient and all hospitals around the country were paid by line items according to number of beds, number of buildings. So, and use this.
We don't have your presentation loaded at the back. I don't know if you have it or do you want to?
Apologies, we're just trying to sort out the slide.
Yeah,
His presentation.
We can connect. So that's it.
This will not work.
Oh, okay. So because of old practice to use line item budget for healthcare providers, the hospital infrastructure in the country very massive and very outdated. And the government started health financing reform to introduce strategic health purchasing in general healthcare system. From my experience in Eastern Europe and Central Asia, usually TB always outside of this movement. But in Ukraine, we decided to propose, together with Global Fund and WHO experts, the similar approach for TB services, strategic health purchasing approach. The main reason is that in country, a very, very huge hospital infrastructure for TB services. You can imagine it's around 21,000 TB beds in the hospitals. It's around 10% of all beds in the country and around 280 specialized TB facilities. So, and when we conduct some analysis, we realize that around 40% of all hospitalization it's really avoidable hospitalization, which can be treated outside of TB facilities. TB still vertical system outside of general health financing reforms. So, during this project, we propose to better match payment to TB priority services from building to people and introduce something like new payment mechanism, very similar with DRG system. Another aspect of the project is use data for decision monitoring and action, not just for reporting and for data collection, and create effective process and policy dialogue on all levels. We started from creating patient database, and within about 50 TB hospitals in country, all patients for last 3 years was entered into database with clinical characteristic of case and characteristic of patient. Next step, we created patient classification system. According to this classification, each patient can be classified in particular clinical groups, clinical diagnostical groups, which different by first classification is TB and not TB cases. Then within TB cases, classification pulmonary and extrapulmonary TB, then bacteriologically confirmed and clinical diagnosed, then drug resistance category, and then some comorbidities which shows the clinical characteristic of the cases. After this clinical hierarchy, all patients in database were classified in particular clinical groups, which very different by cost and length of stay and other characteristics. When we analyzed a database, we realized that around 41% of cases in TB hospitals are really not TB. It can be carriers and can be some contact person with TB patient, and those patients was just put to TB hospitals just to provide diagnostical services and stay in the hospitals within 2 or 3 weeks, just to keep beds busy. And you can see this graph, and blue, it's yellow is now length of stay. Blue, number of cases. And we can see when number of cases became lower because of season, length of stay increased immediately. So very direct correlation. We can see clear that hospitals trying to keep beds busy, and if it's less patients in the hospitals, the length of stay increased dramatically. They keep those patients who in the hospitals a few more days. And it's very powerful analysis with multiple hospitalization. Here, timeline and episode, or each episode of hospitalization, different colors, a different level of drug resistance. Each new episode hospitalization for each patient provide new level of drug resistance, from monodrug resistance to extra polydrug resistance. So, and we can see clear picture that intensive hospital infrastructure provide patients with more complicated cases with high level of drug resistance. And after costing study, we realized that cost of the same patient, like for example, pulmonary sensitive TB in different hospitals can be different in 3 or 4 times, depends on just size of infrastructure, not depends on clinical or economical reason. And after that, we created a simulation model for TB optimization in the country, just to see what can be done with this infrastructure. We can see here number of bed days, number of admission, and budget for TB hospitals in the system, and the number of admission and bed occupancy rate in 4 hospitals in 1 region. And we realize the system when managers can exclude from hospitalization not TB cases, then provide length of stay not according to real situation, but according to international protocols. And we see that number of bed days, number of admission, and potentially budget savings can be very, very huge. And the question is, do we really need 4 hospitals in this region, or it's enough just 1? And if we can relocate savings from hospital sector to ambulatory sector in the country. After this analysis, a lot of regions started real reform in health and TB infrastructure, and close physically a lot of TB facilities which are really not necessary, and reforms started in real practice because powerful information and analytics provide good basis for decision making and for policy decision and approach. Thank you very much.
Thank you, Andrei. I think it's a nice example from Eastern Europe, where certainly a lot of struggles with treatment outcomes and the use of inpatient care for TB. So nice to see that work from the Ukraine.
Our next speaker is Cheng-Yi Lee. He's from Taiwan. He is an associate researcher and senior epidemiologist and health policy officer at CDC in Taiwan. He has worked in the field of TB for 15 years and has a bachelor degree in public health and studied health economics during his PhD. At CDC, his work now is mainly focuses on cost effectiveness analysis of health policy. Go ahead.
Good morning, everyone. Today I'm going to share with you the Taiwanese experience because we have a new program design. We call it Payforperformance program. Every year we join the IUATLD meeting, and after we go back home and we write a trip report to our director, and such as this, we need more cooperation with all levels of healthcare provider, and we need to find out cost effectiveness of approaches, and we need stronger delivery quality monitor system. And we ask our director for more resources and for more budget, but eventually nothing happened because those points, they are all good points, but they are challenges. I'm going to give you a very brief review in Taiwan. Taiwan has 23 million people, and we have about 10 to 11,000 new cases per year, and we got 600 deaths per year. And in Taiwan, the majority TB cases are elderly. Here is the TB care system in Taiwan. I try to let you understand what the role of the Payforperformance and the DOT program. Traditionally, the patient goes to the healthcare provider and seeking for healthcare and get medications from the doctor and then go back home and care by the public health authorities and will provide the DOTS programs. I think you know these kind of things. But in Taiwan, the Taiwan CDC and the National Health Insurance, we cooperate to design a new system. We call it Payforperformance. We ask the healthcare providers to do the case managers and to do the TB case finding to help the public health authorities. And here is how the Payforperformance work. There are 4 key elements to implement the Payforperformance. The most important part is the physician part. We recruit the physician as the chest specialist or infection, TB, or Taiwan CDC trained physicians. And the second part is the hospital and clinic. Every 100 cases, the hospital should hire 1 full-time case manager to be the bridge of the public health authorities and to provide the medical records to the national TB system. They need to do the data entry so that the public health system can understand what the side effect is and can understand what the real situation of the patient. And we also provide the financial incentive, includes 3 parts. The first part is the case finding fee, and the second part is case management, and the third part is treatment success. And we also have an audit system. We call it quality indicator and the auditing system. We publish the performance quality reports monthly to the stakeholders, such as the public health supervisor or supervisors in the hospitals. And the Taiwan CDC and the National Health Insurance will audit the program. And the P4P physicians will receive additional $210 than non-P4P physicians, which is accounted for 7% to 10% in total, higher than regular treatment. And the P4P and non-P4P physicians will receive the same reimbursement for the treatment and the examination and the drugs. And here's my material and methods. We try to analyze our database with the Taiwan CDC TB system and the National Health Insurance. And we calculate the cost, include the direct cost and the indirect cost. Direct cost means the medical expenses. Indirect cost stands for the travel and the productivity loss. And we calculate the effectiveness, use the treatment success. In this slide, you can find out that in the group A, because of the two program combination, so the cost is the highest. For the regular treatment without P4P or without dots, this is the cheapest. However, we find that in the group B, for the P4P only, the enrollee, we find out that the direct cost is not so much, and the indirect cost is the least. So that the total cost from the societal perspective is the second cheapest comparing to the regular treatment. And here we come to cost effectiveness analysis. We use the ACER indicator. ACER stands for average cost effectiveness ratio. It means how much you should spend to treat a treatment success case. We find out that for the P4P cases, this is the cheapest. Therefore, we find out that for the P4P cases is the most cost effectiveness program. And for the P4P and the DOTS program combination is the second. For the regular treatment, we find out that this might be the cheapest total cost. However, we find out that for the regular treatment, it costs the most. And here are the take-home messages. In the societal perspective, the P4P is more cost effectiveness than DOT program. And we find out that the providing financial incentives could increase the direct cost, but it will incur less indirect cost. And we also find out that quality indicators for structural process and outcome should come with the P4P program. Thank you for your attention.
Thank you very much. A different perspective from a lower burden country, and certainly the issue of payments and incentives are something that is always an issue to be evaluated. It was a nice evaluation of that. So we have a few minutes. If there are specific questions, we'd ask you to come up to the microphone for these presenters. Does anyone have any questions? Okay. So thank you very much to all of you. And could we ask the next four presenters to come up? I don't know, Carol, if you want to have their names in order.
I think we have Nadia, Juliet, is it Famieta? And okay, thank you. Did you want to say something, Jacob? Okay, I think our next presenter is Juliet, who is an assistant professor of global health in the Global Health Institute at the University of Georgia. She is a Ugandan physician trained in public health and health service research. Her research primarily focuses on active case finding to enhance earlier detection of infectious cases of TB and TB-HIV co-infection persons in Africa, and also evaluating cost effectiveness of case finding strategies.
Thank you very much for this opportunity to speak at this conference. My talk is going to be on cost effectiveness of pulmonary TB case finding among high-risk communities in Kampala. Where do you move? Is this the thing that moves? Okay. Oh, sorry. I went up. Okay. So we all know that passive case finding is a strategy that, by and large, has been documented to detect at least an estimated percentage of cases, which is about 60% in most regions, most countries. But as we see this, we know that about 40% of the cases remain undetected. So what this means is that these 40%, or even in some cases even 50%, of the cases that remain undetected really are the ones that are perpetuating the transmission of TB in communities, especially in high-burden countries. So active case finding has already been shown as one of the strategies that can be employed to detect those undetected cases. And when I talk about active case finding, I'm really talking about a broad range of approaches that are used to find those undetected cases. For example, household contact investigations, where you would identify an index case at the clinic and then follow them up to their households and then screen the entire household because these are high risk. And then there's also the enhanced case finding, which primarily is more proactive, co-health worker-driven efforts to try to get the cases, or at least patients who are presumptive of TB, to come to the healthcare facilities using various methods. And people have used different approaches, such as raise awareness and educational materials, educational flyers, using mass media. So there's a whole broad range of methods that can be employed to achieve enhanced case finding. So we know that these methods of active case finding have been shown to be effective in detecting additional cases. However, what we don't know, or where we have very limited evidence, is on the cost effectiveness. And that has almost been a huge bottleneck for people adapting, especially national TB programs. They know that, yes, active case finding works, but then when it comes to the cost effectiveness aspect, there's always a gap in knowledge, and so that has caused programs not to adapt the active case finding methods. So we conducted a study to evaluate the average cost of detecting a TB case using the standard passive case finding compared to a combination of strategies. And then we also wanted to evaluate the cost effectiveness of combining passive case finding, enhanced case finding, and household contact investigation, and compare it to doing passive case finding alone. So very quickly through the methods, we used a study population that was around, especially slum areas. We engaged different populations around slums in Kampala, and this is what we define as high risk, just because of the nature of the crowding and the nature of the access to care and many other things that are going on between January and December 2015. And the study inputs were probabilities, cost data, generated from either programs or projects that were doing enhanced or active case finding, or even the national TB program data from the health facilities that are serving within those settings, within those communities that we designated as our study population. And then we also wanted to know what the yield of TB cases would be from all these range of approaches. And then the perspective that we chose to take was the health provider perspective, recognizing that this is limited, but this was of most interest to the national TB programs because they are really interested in what does it cost them. Obviously, the most ideal way to approach this would have been the societal perspective, which incorporates the caregiver costs and the patient costs, which is very important even now as we speak about catastrophic costs to the patients. But this is outside the scope of the interest of this study, and so I won't present that part. And then we did an ingredient-based approach to costing, which looks at includes staff salaries, includes lab tests, travel to go to the households when you're doing contact investigations, and also the awareness type of campaigns which led to the enhancement of case finding. And then the effectiveness measure is included the number of bacteriologically confirmed TB cases identified. And our outcome is the incremental cost effectiveness ratio, and I will talk a little bit more about that in the coming slides. So we used a decision analytic model to try to come up with what we would expect. And so the decision model really is just a way of structuring different options that you would want to compare. So to speak, these are the competing type of strategies that you're really wanting to select which one is the most optimal over, let's say, the standard of care. So in our case, the standard of care, of course, is the passive case finding, and we wanted to compare it to the combination, which has the 3 strategies, doing passive case finding on top of, and on top of that add enhanced case finding and add household contact investigation. And so what you see here is really just the model that shows you the pathway, a potential pathway that a patient would take. So on the top, you can see that once a patient enters care, if they take the passive case finding alone route, then that means, it would mean that, sorry. So they would go up that route, and then they would go through a different series of evaluations, whether they have chronic cough, 2 weeks or more, and then they would either be diagnosed by sputum microscopy or could be diagnosed by GeneXpert. And all those, at this point, you're really tracking the patient through a process or a pathway until they reach the end point, which is the detection. And all along, they're really picking up costs on the health provider side. And that would be the same if they were detected through this route. So this is what basically this model shows us. But at the end, we really want to generate the expected values in costs and effectiveness, which is the yield of TB cases. And this helps us to get an idea of what would it cost, what would be the average number if we repeated this process many, many times. That is basically what the expected value would tell us. So for our results, we found that generally the yield of active case finding over this 1-year period was about 4,750 cases from passive case finding after screening about 12,000 presumptive cases. And then when you combined the whole range of combinations of strategies, then you would be able to detect about 5,000 cases. And then the average cost for PCF alone was about $900 compared to about $4,000, or let's say $4,900 for the combination. So for the incremental cost effectiveness analysis, which is really trying to tell the policymaker, if you did passive case finding alone compared to doing the combination of the 3 strategies, how much would that cost you to detect that additional case that you're trying to look for? This is what this result shows you. So I'll just quickly walk you through the key numbers in this table because I purpose to not take too much time again because of the limited time that we are given as speakers. But what I highlight here is, as you can see, this first... Do you see the point? Okay, good. So this effectiveness number is really telling you that expected value. So if you screened people through this passive case finding alone, you would expect, after spending this amount of money, you would detect roughly 10 cases, let's say 11 cases. But if you compared that to the combination here, this is what you would end up spending, and then you'd detect, or this would be the yield or the effectiveness, about 24 cases. But the number that is really important here is the ISA, or the incremental cost effectiveness ratio, which is about 8,200 over there, which really tells us that to detect that additional case when you're doing all these 3 things, this is what you're going to be spending. And I'm going to say a little bit more about that. And what this, and I've already said what it represents. So you're really comparing it relative to the passive case finding and saying to detect an additional case doing these 3 different strategies within a setting, you're going to have to spend roughly 8,200. But we also went ahead and did a a one-way sensitivity analysis. And it's important to do the one-way sensitivity analysis or even two-way sensitivity analysis because this helps you to see what type of variables that you have put in your model are really sensitive to this ISA, to the incremental ratio. What would you change to make this cost different or even more cost effective? So the ones that turned out to be very sensitive, the three variables that turned out to be very sensitive to the ISA were the number and yield of household contacts, the yield of TB cases from the enhanced case finding, and the probability of chronic cough. So all these numbers, for instance, if you increased the yield, let's say by 50%, that would, the yield from ECF, that would make it more cost effective in the combination arm. Or if you increase the number of people that you're detecting through the household contact investigation, then that means that, or the number you're actually screening in that household contact investigation, that means that the cost effectiveness in that arm would actually increase. Or if the probability of cough would increase. So that speaks to how many people are you able to identify with chronic cough and how much are you able to kind of hone in on those people who are actually having chronic cough, so that kind of increases your yield. So in conclusion, passive case finding, ECF and household contact investigation, which is a combined strategy, actually doubled the yield of TB cases, as you saw. So 10 for passive case finding alone and about 24 for the combination. So that's a good thing. It shows us that doing the additional stuff really helps. However, it was not cost effective from the provider perspective, and the reason it wasn't is because we set a threshold, and that threshold is really like 2 times the GDP of Uganda, let's say, which would be about $1,200 US dollars. So what that says is that the government probably will not be willing to pay above 2 times their GDP. But the point that is important here is that in this moment when we are really trying to accelerate TB elimination, household contact investigation and enhanced case finding approaches should still be considered as case finding, because we are really trying to hone in and zero in on every single case and detect it. So my recommendation would be to find more innovative, low-cost ways to improve implementation of household contact investigations and enhanced case finding. And we've seen a lot of many innovative ways during this conference that I've learned about, which is a cool thing. So this gives me hope, and I hope we can find so many other ways to sort of cut down the costs that are incurred during the household contact investigations and the enhanced case finding. Thank you very much.
Thank you, Juliet. That was really nice. I think with the new targets and global plan, it's very clear that and as you rightly said, we're missing huge proportions in Uganda. The new prevalence survey results come out, and we know many people with TB are missed, and these kind of analysis really help to think about what the best ways of finding them are. So thank you very much for that.
So our next presenter is Nadia Gekelev, who is a doctor in health economics, and she has a PhD in economic evaluation of health technology. She has also worked for the French Ministry of Home Affairs and also WHO in Geneva, as well as the epicenter in France.
Okay, thank you. So, good morning, everybody, and thank you to giving me a chance to speak today. Next. So, the objective of this presentation today is to present you the results of the cost-effectiveness evaluation of introducing the TB-LAM test into the diagnostic algorithm of HIV patients with symptoms of TB in Homa Bay, Kenya. The determined TB-LAM test is a TB urinary lateral flow assay for HIV patients that does not require equipment, infrastructure, give us fast results, and can be used for HIV patients who are not able to produce sputum. So, however, cost-effectiveness evaluation are important to help decision maker and to guarantee efficiency in decisions. In our study, we compared 3 pulmonary TB diagnostic algorithms. The first one, the conventional, with clinical exam and radiological exam. The second one, with a clinical exam, radiological exam, plus a lab test. And the third one, with a clinical radiological exam, plus a lab test and expert test. For the cost evaluation, we took the health service perspective and we used the micro-costing method or ingredient-based method. It means that all resources were evaluated. And for the outcomes, we took the number of screening and treated cases. Then cost and effectiveness of algorithm 2 and 3 were compared with the conventional algorithm, and we calculated the cost effectiveness ratio and the incremental cost effectiveness ratio. And as the study was more than 1 year, we applied a 4% discount rate for both cost and effectiveness. And finally, we compared ICR through a threshold value of 2,580 euro, which is the 2-time Kenyan GDP in 2013. So the results, 474 patients were included in the study. I don't know if it's more. Okay. So as you can see in the table, when we introduce only the lab test, the total cost increased by approximately 2,300 euro. And when we introduced the LAM and expert test, the total cost increased by 3,400 euro. And it results in increase of the mean cost per algorithm by respectively 5 euro and 7 euro. And regarding our key spending, the cost effectiveness ratio was more advantageous for the clinical radiological LAM expert algorithm compared to the conventional algorithm. This one. We can see that this algorithm will reduce the cost effectiveness ratio by 170 euro, and when we see the incremental cost effectiveness ratio, we can see that for the clinical radiological LAM algorithm, it was 114 euros and 131 euros for the clinical radiological LAM expert algorithm. And also, you can see that the difference between the two algorithms was not used, only 18 euros. We also performed sensitivity analysis. The first one was about the discount rate, and the second one was about the variation of the generics per cartridge price. And the sensitivity analysis didn't change our results. In conclusion, we can say that the introduction of the TB LAM test doesn't represent an excessive cost. An algorithm, including LAM plus expert, was highly cost-effective to diagnose TB for HIV-positive patients. And thank you very much for this.
Thank you very much. The new diagnostics that are not expert, I think, are sometimes struggling to gain some traction in many countries. So it's nice to see some analysis of how they work. Can I go on to the next?
Yeah, we now have Sophia Haddad, who is a PhD student in epidemiology at the McGill International TB Center. Sophia works on diagnostics and patient mortality in the Indian TB epidemic.
So I apologize, I've more or less completely lost my voice, so we're going to keep this short and sweet. And today I'm going to do my best to describe to you a cost analysis and the health systems perspective of a upfront gene expert testing of pediatric presumptive TB patients in India. Between April 2014 and June 2016, the Foundation for Innovative New Diagnostics provided free upfront expert testing of pediatric presumptive TB patients referred from either the public or private sector in Delhi, Hyderabad, Chennai, and Kolkata. Through the 2 years of this experiment, they tested a rather astonishing 42,000 patients with 46,000 expert tests. The objectives for this cost analysis were to provide updated expert per test unit costs, in which we performed in a bottom-up approach, and provide costs for demand generation outreach activities, which were costed from the top down, and finally to explore the cost dynamics of these demand generation costs and the cost per patient referral. So this is your fairly standard unit cost per batch size for the Delhi laboratory. As one would expect, if you only use your expert machine once per day, that's quite expensive at about $32. If you run 16 tests, which is the maximum you can run in an 8-hour workday, you've dropped down to 13 tests, $13.40. What was unique about our analysis was that for each of our 4 laboratories, for each day the laboratory was operational, we had exact numbers of expert tests performed. So for each day, for each lab, we could place the number of expert tests performed along this curve and provide the most accurate batch size costs for the expert tests for those days. Using those workload-adjusted numbers, we calculated the workload-adjusted average per test unit cost for experts for each of our 4 laboratories. Those are the numbers shown in parentheses here. These figures show in black the quarterly volume of tests performed, and in red, the theoretical capacity if you'd run the full 16 tests for each expert machine every day. And you can see that for cities like Delhi and Hyderabad that were close or in some cases exceeding their theoretical 8-hour capacity, this here reflects overtime conducted in the Delhi lab. The average per test unit cost when adjusted for workload is slightly lower than in Kolkata and Chennai, where the full capacity really wasn't utilized. The difference between these average numbers and the $13.40 shown here, the theoretically most efficient expert price, is a measure of the inefficiencies and unused capacity in these laboratories. I'd also like to point out that the workload did increase over time, which is a good sign. It suggests that the outreach activities were effective in encouraging patient referrals from physicians. We also costed the 3 types of outreach activities that were conducted by FIND to promote the project to physicians and make them aware that they could refer presumptive pediatric patients for free expert testing. Phone calls, we costed at 16 cents per call. One-on-one meetings with physicians were $7.14 per meeting. And continuing medical education workshops that promoted the project were an average of $7.88 per attendee. Across the cities, the average numbers of these outreach activities conducted per quarter varied a little bit, but the overall average spending per quarter was between $1,100 USD in 2015 USD and $1,900. Now, when we look at that broken down by the average number of referrals, you see that the cities that had higher volumes got a little more bang for their buck, and the cities that had lower test volumes were spending more per patient referral. Finally, this figure shows, combined for all cities, the average outreach cost per patient in the black line. Throughout the experiment, the average outreach cost was $1.24 per patient referral. But you see that when we break it down by quarter, the outreach cost decreases over time. This is encouraging, suggesting that the targeting of the outreach activities was more efficient as time went on, even while the number of patients shown here on the dotted line increased over time. Our main takeaway from this project is that we believe it's important whenever possible to look at the cost dynamics with these demand generation activities, because it's the careful calibration of the supply and demand of these tests that will determine the long-term affordability and the sustainability of these projects as they transition to NTP control. And because he's here and I can embarrass him, I'd like to thank Hoo-Jun Son and the rest of the FIND team for their support at this project. Thanks so much.
Thank you very much. Again, I think it's nice to see there's been so many different talks and on different topics, and expert optimization and access is certainly something that at a global level there's a lot of interest in. So again, clearly needs to get more people in the health system and test people for TB. So thank you.
And our last speaker is Fiametta Bozani, I hope I've pronounced it properly, who is a research fellow in health economics at the London School of Hygiene and Tropical Medicine, and works in the area, and area of work is in economic evaluation with particular focus on economic modeling of TB control interventions in sub-Saharan Africa.
Okay, good morning. So the piece of work I will talk to you about looks at priority setting and resource allocation for TB from the perspective of the public health sector. And it moves from the consideration that often when we assess the cost effectiveness of TB control intervention options, we do not at the same time assess whether or not these are feasible in a real world setting. So why is this not moving forward? The green? Oh, interesting. Yeah, okay, it works. So we took the example of South Africa, which has one of the world's worst TB epidemics, and it's driven by HIV. So TB is the single largest cause of death. And in 2015, facility-based case finding, or ICF, intensified case finding, was adopted nationwide for detecting TB cases among HIV-infected health facility patients. So we have evidence from previous modeling efforts that scaling up ICF to all primary healthcare patients is the single most effective intervention that South Africa has at its disposal for reaching the post-2015 TB targets, but it's also the most costly of these options. So there is also substantial uncertainty in terms of how these case-finding interventions will look like in practice. So what patient population, what screening algorithm to use, and the choice of strategy then affects the consequential costs down the cascade in terms of TB diagnostic and treatment costs. So our research question for this bit of work was, how can health system constraints be characterized and empirically quantified to measure the impact that they have on intervention costs? So we moved from the premise that the constraints and the cost of relaxing them are very specific to each setting and to each intervention, and they must be identified and quantified to reflect the real opportunity cost of any intervention, TB control intervention. So we designed this approach to explore with decision makers as a proof of concept whether it is possible to look at the cost effectiveness of TB control interventions in 3 steps. So first, looking at the unconstrained cost effectiveness, so assuming that there are no constraints applying to the health system, then adding in the constraints to see what effect they have on outcomes and costs. And then the third steps would be to quantify, in case there is a difference between the constrained coverage of the interventions and the unconstrained coverage, how much would it cost to relax these constraints? So what can these constraints be? We, as a proof of concept, decided to look at 3 potential health system constraints that we think affect interventions in South Africa. We based this on the literature, and then we discussed this with officials and stakeholders at the National Department of Health. So we looked at the financial constraint, characterized as the TB budget, and then we looked at the direct constraints affecting access to services. So we decided to look at availability of human resources to deliver TB services. And then lastly, we looked at a policy constraint that I'm going to explain to you in a minute, characterized as the maximum number of expert tests that can be performed in a year. And so the TB control interventions that we looked at are the ones that the Department of Health is considering for the new national TB plan that covers the period 2017 to 2021. And our focus is, as I said, on facility-based case detection, and to calculate the outcomes under each intervention scenario, we use the time transmission model. And then to the model outputs, we attached the cost per service, the unit cost per service, the minutes of staff time per service, and the number of experts to calculate the financial and human resource requirements under each intervention scenario. I'm not going to go through these in a lot of details, but just to say that the interventions that we looked at include the status quo, obviously, so the base case, and then we looked at two different screening algorithms. One using the cough triage, so a single cough question asking patients whether they've been coughing for more than 2 weeks. And then the other screening algorithm was the full WHO symptom screener, which is a longer list of symptoms that are more specific to TB. And then we looked at combinations of these interventions together in 2 different populations, either just the HIV clinic attendees or all primary healthcare patients. And then in terms of the constraint scenarios, we had 3 levels of potential restrictions on the outputs based on what we thought would be the future availability of budget and of human resources. So we had a more restrictive constraint, a medium constraint scenario, and then a least restrictive scenario. And then for the policy constraint, so the number of expert tests, we characterize this as a multiplier on the number of tests that South Africa is willing to buy per notified case, because we know that when they budget, they cap this ratio as 20 tests per notified case. And this doesn't depend on the budget. It's just a political consideration of the viability of expert, basically, in the country. So the last bit of methods that I'm going to cover is how we went about estimating the available human resources minutes per year in South Africa and the cost of relaxing them. So we tried to use, well, we had to use routine data. So in terms of how many minutes are required to provide each TB service, we used data from the DHIS and then from available trials measuring time use in TB service provision. And then for the cost of relaxing this constraint, so hiring more human resources, we calculated this from routine data from the South African Nursing Council, and we assumed that some minutes could be generated from nurses that already operate in the health sector, but in the private sector in South Africa, and then additional minutes had to be procured by hiring and training new nurses. Okay, so what we found very quickly, I hope you can see that. So this figure shows the human resource requirement for each service under the base case, so assuming that no new interventions are introduced. And it shows how the most demanding TB services in terms of nurse time are case finding, particularly when we use a WHO symptom screener because it takes longer to administer, and then followed by first-line treatment and then isoniazid preventive therapy for HIV-infected patients. And here we compare the financial resource requirement under the expert constraint and the high and medium human resource constraints to the unconstrained scenario. So the expert constraint restricts the coverage of all interventions, including the base case, potentially. So case-finding interventions, numbers 6 to 10 in the graph, are the most impacted by a cap on the number of expert tests. And this is obviously a result of the fact that we expect larger numbers in need of testing when we adopt screening strategies that have a higher yield. Whereas the human resource constraint, on the other hand, only restricts the use of the WHO symptom screener because that's the most human resource intensive, so intervention 7, 8, and 10 in the graph. And lastly, here we're showing the additional nurse minutes needed to achieve the unconstrained intervention coverage. So how many of those minutes are already available in the private health sector, and the total cost of providing additional minutes that are not currently available. And we show the split between salary costs and training costs. So there are only 2 scenarios where the additional human resources can be sourced from the private sector, and they both involve the less human resource intensive cough triage. The most costly scenario involves reaching full coverage of the WHO symptom screener among all primary healthcare patients. And the cost of hiring and training a sufficient number of nurses in this scenario between 2017 and 2035 are approximately $3.7 billion, which corresponds to about 70% of the current budget for TB in South Africa. So that would be a 70% increase on the current expenditure. So in conclusion, we tried to show with this piece of work that locally relevant routine data, the literature and ongoing studies and expert opinion can all be used to try and empirically estimate the health system constraints that apply in real-world setting and how much it would cost to relax them. So the most limiting constraint we found to be human resources and policy decision rather than actual budget. So money doesn't seem to be an issue as much as other health system constraints. So to achieve the full coverage of the most human resource intensive case-finding interventions would require up to 15% of all human resources currently working in South Africa to be reallocated to TB. And hiring and paying these additional nurses to deliver these interventions requires a budget increase of approximately 70% compared to current expenditure. So one limitation of what we tried to do is that data quality and availability are a potential limitation to the approach that we used. And the next step would be to try and figure out which TB screening interventions would be cost effective if placed in the real world setting of South Africa. Thank you very much.
Thank you so much. I think, again, a nice summary of the importance of looking at how specific interventions might work. I have one question, actually, and if others, please come up for questions. But if you could talk a little bit about, in many countries, these kind of screening approaches are done not by nurses, but by lay workers or even janitorial staff, which obviously have far lower costs than having a nurse spend that time to do it. So I was wondering if you looked into that at all in terms of task shifting and allowing something that probably nurses don't need to do to lower potential costs.
Yes, thanks. We did get costs for task shifting, so for using community health workers instead of nurses. We did not present that because that currently is not an option in South Africa. Because although it would be cheaper in terms of the unit cost of providing the service, because they're not routinely used, community health workers in South Africa, they would need to be trained and employed across the board, basically across the whole health system, and that's a huge upfront cost. So basically, we're not really sure that in South Africa that would be the cheaper option currently because because community health workers are not used in the South African health system at the moment. But it would definitely be a good solution in other settings, potentially.
Thank you. Hojun, do you want to?
Hello. Okay. Hi, Hojun Song from Johns Hopkins, and thanks for great presentations. It's great to see all these health economic evaluations going up, lots of variety of interest going on there. My questions are for first two presenters and also some comments after that. So primarily, I wanted to see your primary outcomes are all evaluated in terms of number of additional cases diagnosed, and your conclusions are all based on that. Now, my understanding of being cost-effective, where you compare to GNI or GDP per capita, it's usually, and this criteria has been, no longer it applies anymore based on the WHO, and that's based on how each program evaluates itself. But previously, it's been weighed against the DALYs, the incremental cost effectiveness ratio, where effectiveness measurements are based on DALYs there. If you project that towards in terms of number of DALYs averted, then the cost effectiveness ratio may go down from $8,000 or in yours, maybe a lot lower than that. So I wanted to make a quick comment about that, but ask you, when you include costs, do you include costs beyond diagnostics, so including cost of treatment, and whether or not how that factors in your models? And then secondly, the question is, the models, whether or not you, in the active case finding components, do you incorporate any kind of patients potentially coming back in the system in the passive case finding? Because previously, in my my modeling exercise, so when even if you build a cost effectiveness model, you have to target your you have to adjust your model so that your projection for passive case finding matches the passive case finding levels that are provided or reported in the general consensus. So based on your initial finding in Uganda, it seems like it's 38% that from your model results. That's much, much lower than what's been kind of reported, where you said in the introduction about 60%. So I wanted to kind of raise those questions and yeah.
Yeah, so that's pretty long, but I'll just take a shot at it. And you do raise very, very legitimate questions. And as I highlighted at the beginning, these are only the very beginnings of beginning to even do the cost effectiveness analysis. Yeah. Yes, we would like to do a more comprehensive job, including using DELIs or even QALYs as the outcomes of interest. Yeah. But more, I would say, one, most of these cost effectiveness analyses are driven by what's most important right now, especially for programs. A program manager or policy makers, yes, they would appreciate knowing the DELIs and the QALYs, but more importantly, the targets that they focus on are the cases that they detect. So we kind of want to be able to do studies that align with the interest of what would drive the decisions that they would make at a programmatic level. Yeah. So that would be one. But of course, this in some ways underestimates the impact of some of the strategies that we are looking at. For instance, if you're looking at active case finding and household contact investigations, we would much like to add the future cases that are averted, because the active case finding effect does not only end at detecting the case, but you've really prevented some cases, and that has a much greater weight in the grand scheme of things, because we are really trying to eliminate TB. So in thinking and in agreement with what your comments are, we definitely need to do more comprehensive cost effectiveness analysis, include the more long-term future outcomes that would be able to capture the entire picture. Okay, I hope that answers somewhat.
Yeah, no, just to piggyback on that, I don't know if you have time, and I certainly don't want to hold the microphone, but to comment on that, I think it's important to capture that metric. Especially it's important because it's a direct outcome. Now, when you compare that to a cost effectiveness conclusion, I think you need to justify more than just saying that it's below GNI or GDP per capita, because that comparison in previously it was compared to the DALI metric, and where you have used that to compare different types of interventions and declare whether or not it's cost effective. I think when you compare incremental cost cases detected per cost or costs per case detected, then you have to justify that with other kind of resource constraints that are available. So when you say you have $8,000 to invest per case detected, how does that translate into budget constraints and other things to make that case where it's cost effective for the program or cost not effective? Right. It's not simple comparison to the GDP or GNI per capita. Right. That's just my comment.
I agree.
Just to add, I agree with you totally, but if you want to know if our intervention or algorithm is affordable for the country entire, we have to make in-depth analysis with the budget impact analysis. So, yes.
Any final questions? We do have a few minutes left, but okay, people are hungry for lunch. So I just want to say thank you to all of you for attending. Thank you to the speakers. It was really a wide range of topics, and clearly I think this type of evaluation and studies are needed, more of them going forward. A number of presenters have pointed out the lack of information, so thank you very much. And also like to thank Carol, co-chair, for helping organize this, and maybe give her the last word.
No, I just want to also just thank the presenters for coming to share their presentations on the country experiences. It's always good for people to listen to what's happening at country level. So to just say thank you, and also for everybody who's come on the last day to come and listen to our presentation. Thank you.
Just try to see in the dark, just try to